Hey there, part three of the saga of the inflammatory system and tissue healing. So this is kind of everything else. So kind of in summary, I wanted to just talk a little bit about pro-inflammatory chemicals, just to review. So histamine is stored in basophils and mast cells and platelets, and it causes vasodilation. Serotonin, stored in platelets, mast cells, and enterochromaffin cells of the gut. It causes vasodilation. Kinins, um, the precursor for bradykinin is kinagen, and it is triggered by the Hagemann factor 12 of the clotting system, and it triggers skeletal muscle contraction, which causes pain and shivering. And complement, the component C3, C4, and C5a are anaphylatoxic agents, and they come from the complement cascade, and they release histamine. They have chemotactic actions, and prostaglandins plus leukotrienes are triggered by the arachidonic acid release, and they particularly prostaglandins cause vasodilation, whereas leukotrienes cause chemotaxis. So let's plunge into mast cells. They're an interesting player in this whole process. They live in tissues exposed to the environment, like connective tissue. They contain granules, and they release substances immediately through degranulation or over time. So they can work either way. So you can see a little burst of degranulation happening there, or it can kind of ooze out. And some of the things that come out of it are histamine. They also play a role in the adaptive immune system, as you can see, because they are antigen presenters, and they do a lot of different stuff. So when mast cells degranulate, it results in expulsion of histamine and chemotactic factors, the tractor beam stuff. They expel cytokines, which enhance white blood cell migration and vascular permeability, and they enhance phagocytosis. So the result of long-term release are synthesis of pro-inflammatory mediators like tumor necrosing factor alpha and leukotrienes, factors which stimulate growth and angiogenesis, that's making of new blood vessels, like prostaglandins, and they make platelet activating factor, which prompts the vascular response. So they're kind of a intermediary between the inflammatory response and set the stage for healing. So distinguish between local and systemic manifestations of inflammation. Well, let's talk about acute inflammation. This involves a discrete set of events. It can be local or systemic, and healing occurs usually in 2 to 3 weeks, usually leaving no residual damage. In this case, neutrophils are the predominant cell type at the site of inflammation, and that is, like acne or a thorn in your skin or something. That's what that looks like. So you can see it's contained. The redness is contained. Chronic inflammation may last for years. So what happens is these injurious agents, products of inflammation, persist. And one of the key characteristics is that they persist. It tries to heal, and then it re-injures itself through these persistent presence of these pro-inflammatory agents. So the predominant cell types involved in the long-term inflammation are lymphocytes and macrophages. So it can you can have chronic inflammation because of results from changes in the immune system, like, for example, autoimmune disease. So this is sort of shows how the different outcomes from acute inflammation. You can have resolution, you can have suppuration, which is pus formation, results in pus formation. You can have excessive necrosis, and which results in repair and organization or causes fibrosis. Or you can have chronic inflammation, which is caused by some kind of persistent irritant. So what happens when you get chronic inflammation? Well, you can have degenerative diseases like rheumatoid arthritis, or you can have these two phenomena called granulomas and fibrosis. So granulomas are the attempt of the body to wall off a pathogen, and the cells may fuse to form a multinucleated giant cell. So giant cells are encapsulated by collagen. That's what forms the granuloma. For example, a TB tubercle is a granulomatous process with surrounding a TB bacillus in the lung. So another thing that can happen is fibrosis, which is a maladaptive process of resolution healing. So that's the kind of healing that results in a scar. And what ends up happening is there's more collagen laid down as this resolution healing tries to happen, and then it gets undone by inflammatory effects of whatever the chronic source of stress is. So, for example, the disease pulmonary fibrosis is an example where the functional lung tissue is replaced by these fibrotic tissues because there's chronic inflammation, and it's usually caused by some sort of environmental thing like, silica dust or some sort of cancer-causing agent or something like that. Or it can just be a autoimmune condition too. But that's a sidebar. We'll talk more about pulmonary fibrosis another day. So let's look at local versus systemic. So here's a little table that outlines that. So local inflammation, that's when you get the redness, swelling, heat, pain, loss of function. Get the increased neutrophils. You might get an abscess or a pustule. Systemic results in induration, and then you get a whole body response, which causes an increased pulse and respiration, a fever. There's usually a loss of appetite associated with it and nausea, somnolence and malaise, so your level of consciousness is depressed. You have an increased white blood cell count with a left shift, and it can result in sepsis or systemic inflammatory response syndrome, or SIRS. There are two instances of that in the extreme form. So what occurs when there's a fever? So this is a pathomap that shows that. You have this prostaglandin E2 changes the thermostatic set point. So I guess initially what happens is the inflammatory response is triggered. So then there's an increase in this prostaglandin, which then impacts the hypothalamus, which then changes the set point for the body's temperature. Other things that can bring that about are the release of these interleukins and TNF alpha. And so then what happens is the peripheral blood vessels constrict to conserve heat and decrease sweating. And the body makes more heat by increasing muscle contraction and shivering. So, and that all is described as a fever. So macrophages and monocytes secrete cytokines, these interleukins 1 and 6. Also, tumor necrosing factor alpha goes to the hypothalamus and the temperature regulatory center. So these two factors can affect that set point. And then the temperature goes up, and that triggers the autonomic nervous system to do shivering and generate more heat. So that the agents that do that are called pyrogens. In other words, they cause fire. All right, so differentiating between, so this is objective 9, and this we're kind of getting into different tissue healing. So we have all this stuff that's setting the stage for healing. Now we've got healing. So there's two main processes for healing. There's regeneration and there's repair. So regeneration is when the healing is of the same tissue type. There's usually limited inflammation and the basement, and that's when the basement membrane remains intact. It's like when you get a little cut in your finger or something and it just heals up and there's no scar formed. So tissues that can do this are skin, lymph organs, bone marrow, endometrium, mucous membranes. So an example is a superficial scrape or cut. So repair is the most common healing mechanism, and that's when there's more extensive tissue damage. And what happens is there's healing and then replacement of the tissue with scar tissue. Scar tissue is mostly collagen, and it sort of approximates the tensile strength of the tissue, but not always. But it can't do the things that the original tissue could do. So some tissues are able to partially regenerate, like smooth muscle, and some tissues don't regenerate at all, like cardiac and skeletal muscle tissue. So they used to say that cardiac tissue and skeletal muscle tissue, those cells could not be replaced, but there's more research that shows that they can be, but the main concern is that the functionally physiologically effective cells are replaced by scar tissue, which can't do anything. That's why myocardial infarction is such a bad thing, because cardiac cells have all these special qualities like conductivity, and you can't conduct through a scar tissue. So in general, the ground is laid for healing by kinins, macrophages, fibrin, platelets, mast cells, interleukins, and they all play a role in wound healing as well. So there's a bridge between these two effects. So what happens is the inflammatory process occurs. All these constituents of the inflammatory response are disseminated to the site of injury. Some of those constituents are phagocytes, which clean up the debris and the dead tissue. And then as vasodilation decreases, the swelling drains from the tissues and goes into the lymph system, this body sewer system. And then the clot retracts and the fibrin mesh that was there, and then the fibrin meshwork that holds it in place is established. So that's kind of the first underlying things that happen in healing. So here are the steps for wound healing initially. Like we talked about, there's the area is cleaned and removed of debris, which is part of the inflammatory process. Then granulation occurs. This is the organization, otherwise known as the organization phase. So the blood supply is restored, the capillary bed, new materials for the capillary bed are laid down. So there's this fibrin framework, and then these little tissues called cells called granulation cells fill in, and they migrate from the edges of the wound into the middle. And then fibroblasts and collagen fibroblasts move in and create, reinforce the fibrin meshwork, and then there's collagen synthesis. So then there's remodeling, which is when the wound is shrunk and it reshapes. That's when scar tissue forms. And the surface epithelium regenerates, and the underlying granulation tissue contracts and forms a scar, which might not be visible. And then extensive wounds form from a fibrous scar. So the stages of healing are the initial stage, and so this kind of gives you a little ruler of the timeline below here. So you have your inflammatory stuff, then you have your initial stage, and then you move into granulation, and that's when fibroplasia and granulation tissue form, and that's when macrophages are mostly there. And that's when the little buds for the blood vessels are formed. That's when the basement membrane is repaired and it's completed. Then towards the end of the granulation phase, you start to have contraction, and then you move into remodeling, which is where the replacement tissue is about 50% of normal tissue strength. So you can see that this timeline is pretty long. The first initial parts are brief, but it can take years for scars to remodel. And that is something I always try to tell patients, you know, when they're looking at their scars, like, oh my God, how is, you know, this is so disfiguring. And then, you know, encourage them person to know that actually this, you know, a month after surgery, this is not what you get. It continues to improve over time. So let's talk terms. Now there are a whole slew of terms here. So this is just sort of memorization. I might ask you to describe a few of them, but this is going to be very helpful on the exam, but it's going to be very helpful in your charting, in your documentation, because you have to know how to describe skin issues. And so this is how you do it. So you can describe wounds as surgical or non-surgical. You can describe wound thickness as superficial, partial thickness, or full thickness. And that has to do with the skin. Wound margins different descriptors include macerated, erythematous, and excoriated. So macerated is when it's kind of raw, erythematous is red and swollen, and excoriated is chafed. Wound bed can be described in terms of what's in there. Usually it's granulation tissue, although there can be other things there, slough and other materials. Exudate can be described as serous, sanguinous, serosanguinous, or purulent. So serous is clear, sanguinous is bloody, serosanguinous is a little of each, and purulent is pussy. Granulation tissue is one thing that you can find in a wound bed. Another thing is slough. You can have chronic wounds or acute wounds. And we talked a little bit about what a chronic wound is. So adhesions are fibrous bands. Contractions are deformities. Dehiscence is opening of the wound. It is closed and it reopens. Excessive granulation is also known as proud flesh. That's the bumpy stuff that you get on the side of a wound. Fistula is a connection between two body cavities. Hemorrhage is an abnormal bleeding. Keloid is excessive scarring. A skin tear is just a tearing of the superficial area of the skin. It kind of peels back, and it's very common in older people. And undermining is when you have an open wound and this outer skin layer is one size, but there's the inner wound cavity is actually going underneath that outer thing, and it forms cavities and sometimes tunnels. But that's another term you can use in describing a wound. So let's talk more about wounds. There's a chronic wound that lasts for longer than 3 months. You can have, we talked about adhesions already, which are fibrous bands that occur in the process, in sort of a maladaptive wound healing. And contractions we talked about. Dehiscence is when, usually when a wound reopens. That's because the sutures break. Usually it happens about 5 to 15 days after surgery, and it's usually from an infection. Excessive granulation, we talked about that, and fistula and hemorrhage is abnormal bleeding. So those are some terms. So now, primary, secondary, and tertiary wound and tertiary intention healing. It's a way of describing how a wound is healing. So primary intention is like a surgical wound where the wound edges are approximated and there's a wound closure. Secondary intention is an open wound, so the wound is filling in from inside, from underneath, and then it eventually fills up, and then the epidermis closes over. Tertiary intention is delayed suturing, so that's when the wound is left open, is either reopens or is left open, and then you close it up after a period of time to finish healing. So sometimes that happens when a wound needs to be debrided, which is where you cut out the dead tissue. So recognizing factors that may impair or delay wound healing. Factors that affect wound healing, that's objective 13, I should say. So if there's chronic inflammation, that'll influence wound healing. If there's ischemia, this is more or less things that negatively affect wound healing. It's chronic inflammation, ischemia, excessive bleeding, excessive fibrin deposition, other disease processes like diabetes is a good example. Infection, poor nutrition, drugs, and altered collagen synthesis. It's pretty interesting, some of the research that's been done on methamphetamines and how that really disturbs wound healing and can cause some sort of disfiguring wound healing or failure to heal. Chronic inflammation affects, the effects of chronic inflammation include inflammatory infiltrates that move into the interstitial fluid. That's what ISF stands for. There's tissue destruction, mainly by macrophages and fibrocytes. They're the things that break down fibrinogen, fibrin, break down fibrin. There's repair, which is tissue destruction that may induce healing attempts, and they sort of creates a loop effect. So it tries to repair, but then can't. So there's this ongoing effort to repair. There's fibrocytes that lay down collagen. The cell types might change with chronic irritation. And then it is caused by repetitive stresses, genetics, and autoimmune response. Describe granuloma formation. Granuloma formation is caused by accumulated macrophages, fibroblasts, and collagens to form a tight ball, and it interferes with healing, and it can become necrotic, leading to caseous necrosis, which we learned about last week. So that is not the world's greatest picture, but it is just a ball of tissue. So that's a granuloma. And as I mentioned before, a tubercle is an example of a granuloma. So then fibrosis, that's when fibrin tissue replaces functional cell tissue, and that's a result of chronic irritation too. So it's a maladaptive variation of the normal healing process. And what happens is macrophages, platelets, and injured tissues release growth factors which stimulate fibroblasts. They're the things that lay down the fibrin. Fibroblasts make this extracellular matrix into connective tissue. The fibroblasts lay down connective tissue made of collagen. And what happens is because there's chronic irritation, it becomes excessive. And this repetitive stress or deregulation of healing occurs. So then all this fibrin is put down and replaces the functional tissue. This is part of the underlying cause of liver failure. Gain an understanding of bone healing. That's objective 16. We're nearly there. So here, just as a reminder, an osteon is the basic unit of the bone. Osteoblasts deposit bone material, and osteoclasts bring about bone reabsorption. So that's just sort of a reminder. And they all play a role in bone remodeling, which we'll get to. So what happens is you have a broken bone, begins with inflammation, then a hematoma is formed around the break. Then there's fibrocartilage formation, and then there's callus formation. So the hematoma is a brief phase, and then after the initial injury to about 3 days, then the fibrocartilage formation happens from about 3 days to 2 weeks, and that's when the fibrocartilage forms a scaffold for the healing of the bone. And then there's callus formation, which is about 2 to 6 weeks following the injury. And then ossification, which is 3 weeks to 6 months. And that's when there's crystallization of the minerals that are constituents of the bone, and the bone forms and the bone matrix is forming. Then there's consolidation in the remodeling stage, and that is from 6 months to 1 year, and that's when the bone is restored, the original shape of the bone is restored, and that's that process that happens through a balance between osteoblast and osteoclast activity. So bone healing phases include phase 1, which is which includes the hematoma formation. The reparative phase, which is the fibrocartilage, callus formation, and ossification stages. And then finally remodeling, which is the consolidation and remodeling phase, stage of bone healing. So let's talk about the factors that impair bone healing. So you can have delayed healing. People who are elderly or frail, they don't have that mechanical demand on their bone, which stimulates bone to harden. And also osteoporosis is another factor, because there just isn't the materials there to make bone. It makes it real brittle. So that is what I wanted to say about that. So other things involved in bone healing, you can have delayed healing because of fracture fragments, infection, smoking or decreases circulation, malnutrition gives you fewer building blocks, and corticosteroids can play a big role in bone deposition, makes bones more fragile. Also, poor circulation like peripheral vascular disease or arterial disease can result in impact bone healing and bone function in general. And so the people who are at risk are the elderly, frail, people with coronary artery disease, peripheral vascular disease, and osteoporosis. So that is it for this lecture. Thank you for listening.